Hello everybody, and thank you to the conference organisers for inviting us to come and talk about nystagmus. Now I am representing two people, so myself and Helena Lee, which is why I've put our mugshots up on this screen. We work very closely together in Southampton, and just by way of introduction, we're both consultant ophthalmologists. We have a particular interest in nystagmus, and therefore we do see lots of people with PAX6 disease and aniridia, and so that's why we've been invited. Now, I'm aware I'm talking to an audience of professionals and also patients and everything in between, and so I'll try and keep this relatively broad brush, and hopefully there'll be some questions at the end. Unfortunately, I can't make it on the day to the talk, so I apologise for not being able to make it to the conference, but Helena Lee will be there to answer the questions, so we're a double team as usual. So let's make a start. So the first question that you might ask is, why are we talking about nystagmus? This is a aniridia conference. Have I just got the wrong conference? Have I turned up to the wrong place? Now, hopefully I haven't. The reason is that nystagmus is obviously very common in people who have aniridia. So the next question might be, well, what exactly is nystagmus? And if you look at these videos on this screen, or if you can't, don't worry, what I'm showing is pictures of people's eyes moving, and they can move in lots of different ways. So nystagmus is just a particular type of abnormal eye movement, and by definition, it has to be an abnormal eye movement that starts with an abnormal slow component. So what I mean by that is that usually there's an abnormal slow drift of the eyes, and then either a flick back to where the eye should be, or a slow drift back to where the eye should be. And those are the two broad types of nystagmus. One is called jerk and one's called pendular. Now, there are lots of other abnormal eye movements, which are very quick movements in different directions, all sorts of things, but these are by definition not nystagmus, and they're not particularly important for people with aniridia. So that's what nystagmus is. It's an abnormal eye movement which can be in any direction, take lots of different patterns, but has to be starting or has to be initiated by an abnormal slow phase. So the other reason why I'm talking about nystagmus, as well as it being quite common in people with aniridia, is it is often actually the first sign of aniridia. So nystagmus is an abnormal eye movement. It's quite obvious to people around patients, and so when babies first start to have abnormal eye movements, which is usually in the first few months of life, that nystagmus is the first thing that people notice, and therefore the question is, well, what's underlying it? What's the cause? And for a reasonable number, it will in fact be aniridia, particularly if it's a partial form, which people haven't picked up by normal baby screening. So this picture on this slide really illustrates how we look at patients with nystagmus. So when babies are presented to us at a few months old with eyes that are moving and someone thinks it's nystagmus, they go through a huge, great long workflow of tests. So we do lots of tests to try and prove it's this or that, or look for signs, for cause, etc. And one of the important bits of that, which I've highlighted here, is there's one little section which says, is the examination consistent with aniridia? Have you found signs of aniridia? And that's an important thing to look out for very specifically in children with nystagmus, because the way we look after them, the way we investigate the cause is slightly different. And again, we'll hear about this again in other talks, I'm sure, over the conference, about looking for associated disorders with aniridia. So when we look at children with nystagmus, we always seek aniridia as a specific thing to look for, a specific entity. The other things to think about is that, in fact, even when we examine children with nystagmus, looking for aniridia, sometimes the signs can be very subtle, as we know. And again, we'll hear about this in other talks. But for that reason, when we do genetic investigations on children with nystagmus, where there's no clear, obvious reason for it, or the examination is limited because the babies are small, there isn't the right available kit, etc., we always test the PAX6 gene, which is the common gene for aniridia. And this is for children with nystagmus and seemingly not much else. So in the world of nystagmus, we take aniridia very seriously as a potential cause. And for people with aniridia, nystagmus is really common. So the two are very much linked. So the next question, here's where it might start to get a little bit heavy, is why do people with aniridia get nystagmus? Now, as I said, I'm aware that I'm talking to a broad audience, so I'll give two sort of pitches of answer to this question, but it is quite a good question. The reason I've put up this scary picture is that this is the usual face that people produce when we start talking about causes of nystagmus, and there's good reason for that. So this is the complicated answer. If we think about evolution and the evolution of eyes and how they move all the way from the most simple beings, so these are single-celled organisms way back when in evolution, all the way through to the pinnacle of sophisticated evolution and high-level cortical function and high-level eye movements, which is Gareth Southgate, that's a huge length of time, and during that time a lot of things have happened. So at the start of evolution, when organisms became mobile, it became necessary to be able to stabilize the eyes, or the light sensitive bit, while the organism was moving. So while it was moving, it needed to point its light sensitive part towards upwards, or towards the object of regard. And so for that reason, some relatively simple eye movement control systems, so this is neurological pathways, developed. And these are called OKN, VOR and smooth pursuit. And humans still have these. As evolution continued, there became bits of eyes which were more sensitive than other bits, so they were better for vision. And in humans, this bit of the eye is called the fovea, and so it became useful to be able to point the eyes towards the object of regard. So what you were looking for, you tried to put that object onto the fovea so that you could see it as well as possible. And for that reason, we developed some more eye movement systems, again, complex neurological circuits, called saccades and gaze holding. Then in evolution, as we started to get more like humans, more like complex mammals, there was frontal binocularity. So what that means is two eyes towards the front of the head with overlapping fields, able to see in 3D. And so for that, we needed binocular coordinated movements. You needed to be able to move the eyes to get them to both look at the same thing at the same time. And so we developed divergence movements. Now these eye movement systems, all these ones linked in blue, have been stacked upon each other throughout evolution. And so when something goes wrong, such as loss of binocularity or abnormalities at the fovea, what often happens is they get mixed up, and the eyes and the neurological circuits end up reverting to a very old system, which is why we get abnormal nystagmus when these things are disrupted. So, for example, if we look at over the start of one of these systems, the OKN in blue, there's a number of theories that actually OKN is abnormal and starts to reappear in abnormal scenarios when you have a problem with vision. So if you take away good vision from the fovea, what you do is you start to get an old eye movement system re-emerging. So it's a complicated layered system of eye movement control systems, which when disrupted tends to turn upside down, and so these systems are still trying to work but producing abnormal eye movements. That's the complicated answer. A slightly more simple answer to why people with aniridia get nystagmus, and this is a bit more specific to aniridia, is that retinal maldevelopment, so especially at the fovea, seems to cause nystagmus. What that means is that when that particular bit of the retina doesn't develop, nystagmus seems to appear, and we think that's because that part of the eye is actually very sensitive to movement in one direction. There are actually cells in the back of your eye which only fire, these are neurological cells, they only fire when light passes in one direction across them, not when it passes the other. And when the fovea doesn't develop normally, there's disruption to those circuits, and therefore they're firing abnormally, and that causes abnormal eye movements. So that's a sort of basic theory about a number of types of nystagmus, which is probably relevant in aniridia. So retinal maldevelopment seems to be one of the reasons why people with aniridia get nystagmus. Another reason is that lack of binocular vision alone can cause nystagmus. So what that means is that anybody who doesn't develop two eyes looking at the same thing and getting 3D vision from a young age has a chance of getting a type of nystagmus which we call MLN or FMNS. And so it's a really common form of nystagmus. So people with aniridia can get that because often they don't have good binocular vision as well. And the third reason people with aniridia can get nystagmus is because poor vision alone can cause nystagmus. So anyone with severe enough poor vision, nystagmus seems to pop out and be a result, again probably because of lack of sensory input in the developing systems. So essentially people with aniridia can get nystagmus for a number of different reasons, and these types of nystagmus are all slightly different as well. So what problems does it cause? This all sounds very complicated. What does it actually do for people with nystagmus? And actually that's really, really variable. So what it can do in and of itself when you have nystagmus, abnormal eye movements, is it can reduce visual acuity. So when you read down the chart, you can often get less far if you have nystagmus. The second thing it can do is it can actually increase the time to see. So that means that walking around in the real world, you may be able to eventually see a letter or read something on a chart, but it will take you a lot longer to do it. And that becomes a problem because in the real world, obviously, speed of seeing is really important. The third thing it can cause is cosmetic problems for some people. It also probably increases refractive errors. So if your eyes are moving horizontally, which is the most typical direction in aniridia, if they're moving horizontally and constantly throughout your life, what tends to happen is the cornea rubs on the eyelids and you increase your astigmatism, meaning that glasses are more necessary. Rarely you can get oscillopsia, so this means that there's a sensation of the world moving. So some people with nystagmus will say at certain periods in their life, they will have noticed that they've just has a sensation of things moving, and that's because of the nystagmus, although it is quite rare in aniridia. And the final thing is that it can cause difficulties with examination. Some of you may have noticed this. If your eye's moving, it's quite difficult to check the pressure of the eye, for example. Sometimes it's difficult to image the back of the eye, and this has relevance particularly when checking for glaucoma and things like that. So it can cause an array of problems, but some of them are relevant for some patients and some are absolutely not for others. So what treatments are there for nystagmus? This is a question we're also asked quite a lot. Now, broadly, there are quite a few different categories of treatments, but again, at risk of sounding boring, it depends on the situation. It's very different for every patient. So broadly, the treatments we have for people with nystagmus are trying to treat the underlying condition which has caused it, which sounds silly, but actually it's not. So in my other part of my job, I do cataract surgery on little tiny babies, and this is often within the first few weeks of life. Some of them will have developed nystagmus because of their cataracts. When we treat the cataracts, the nystagmus absolutely can get better. Similarly, there are retinal dystrophies which we're trying to treat at a molecular level, and also, as you'll be hearing again at other parts of this conference, there's treatments potentially for PAX6 disease, for aniridia, which are really designed to try and treat the initial problem. And those are one way of helping with nystagmus, but it's kind of an indirect route. The second thing that we tend to use in people with nystagmus, just broadly, is contact lenses. There's a few reasons why this can be helpful. What they can do in some circumstances is reduce the wiggle a little. They don't do it a lot, but they can certainly for some patients. Some patients feel that it absolutely improves their vision beyond what the improvement from glasses, and some of this may well be because the contact lenses are in the right place on the eye despite movement more often. Also, contact lenses can be designed with some pigment around the edges so they can help with photophobia, so problems with bright light. So contact lenses do have a role in people with nystagmus and in people who have abnormal front of the eye with nystagmus. But in aniridia we have to be a little bit careful because of the problems with the cells around the edge of the cornea called the limbal stem cells, which we know are sick in forms of aniridia. So we have to be careful that contact lenses aren't irritating or making that worse. Again, I think you're hearing about that elsewhere in this conference. The third treatment we have for nystagmus are medications. Now, most of these medications treat lots of things. They're quite broad and they come with quite a side effect profile. So some patients can benefit from them. It tends to be relatively modest improvements, to be honest. But again, we have to think about the context here. People with aniridia will have had nystagmus mostly all of their life. They would rarely experience the sensation of the world moving, whereas if you get nystagmus for a different reason as an adult, that sensation of the world wiggling, called oscillopsia, is the most maddening symptom ever. So you will try any medication to get rid of it. And that's not so relevant in aniridia because you don't tend to get that sensation. So medications can have a role, but not so frequently, to be honest, in aniridia. Head posture surgery, you may have heard of. What this involves, it sounds like a big surgery, we're moving the head around. We're not really. What this is for people who hold their eyes in one particular direction because the nystagmus is better in that direction and their vision is therefore a little bit better. And what we can do is move the muscles on the eyes, a bit like a squint surgery, to try and move that favoured position to the middle. And that can be relevant for people with aniridia and nystagmus. But again, it's very nuanced by which particular type of nystagmus, what the head posture is, etc. And then there are other surgeries in the eye muscles. If you Google surgeries for nystagmus without any other details, you'll find people who've done all sorts of interesting things on eye muscles, such as taking them all off, for example, which can indeed stop the eyes wiggling, but it also stops the eyes moving at all. So there are lots of different types of surgeries which have been tried, but mostly these aren't done in the UK, and there's fairly good reason for most of them. So that's treatments in a nutshell. So by way of summary, again, I didn't want to make this talk too long. By way of summary, nystagmus is very common in aniridia. Lots of people with aniridia will have nystagmus. Sometimes it's the first sign of aniridia. So what that means is that practically people like me, when I'm seeing children with nystagmus for the first time, we look for aniridia very specifically. But also, even when we've looked and we haven't found it, we still sequence the PAX6 gene because it's not uncommon to have kids with nystagmus who have very, very subtle forms of aniridia. And in fact, I've got a number of families who've got such subtle forms that even when we do the really detailed test, looking at the fovea, so that dip at the back of the eye, when we do that, it's incredibly subtle and easily missed. And the rest of the eye looks very normal. So it can be, when it's a really subtle case, it can often, we're surprised, but that's exactly why we sequence PAX6 in all kids, or pretty much all kids with nystagmus. The other thing to mention is that there are a number of different types of nystagmus and they're caused by different things. So as I've mentioned, I appreciate some of the complexities are a bit difficult to explain in a short talk online, but essentially the thing to remember is that nystagmus is not all the same. So everybody with nystagmus will have a different cause for it, but also the type of nystagmus makes a big difference to where it's come from, but also what we can do about it. So what that means is that treatment just depends on lots of factors, including the cause, the symptoms, and the type. And in the context of aniridia, rarely is the cosmesis a major reason to do things, so the way it looks a major reason to do things. And actually a lot of patients have significant problems with vision for other reasons, as most of you will know, and therefore the nystagmus tends to form a relatively minor part of what we see, but it totally depends on each case individually. So finally, a quick thank you slide. This is a thank you to all the people who help out in our clinics and through our research and all other bits and bobs. These slides, to be honest, are out of date as soon as you've written them, so I might stop doing these at some point. But broadly, just thank you to everyone who helps with all the stuff that we do in our clinics and elsewhere. But most importantly, and the most useful people to us are the patients that we have. So thank you to all our lovely patients, and hopefully we will catch up soon face to face. Have a good conference, and I'm sure Helen will be able to answer your questions excellently. Thank you.